So the word innovate means to develop something new or different. And what we hope to do when we innovate is to develop something that's better and an improvement from what's there from a previous venue. And in medicine, the way we tell if something is better is by doing a phase 3 trial. We have a standard treatment that's been around for several years. We develop a new treatment, and we want to compare it to that old treatment to see whether the innovation really makes a difference, or whether it's just a more expensive Me Too type of treatment, or whether it is even inferior to the treatment that's been used in the past. So I deal, among other things, with testicular cancer. And testicular cancer accounts for only 1% of all male malignancies. But it's the most common cancer in young men between the ages of 15 and 35. And so because of the potential of productive years of life lost, this is an extremely important disease. For example, the most common male cancer by far is prostate cancer, where the average age is in the 70s. And not that it's not tragic if someone dies in the 80s or 90s, but compared to someone dying in the 20s, it really does make a major difference. Now, as an oncologist, when we see a patient with metastatic widespread cancer, most of the time the goal is palliation of symptomatology and prolongation of life. But in testis cancer, the goal is different. Our only goal is cure, and fortunately for the majority of our patients, we are able to achieve that goal. Now, testicular cancer has also been a nice model for drug development, and some of the most successful chemotherapy drugs, cisplatin, etoposide, and ifosfamide, were FDA approved purely upon the activity in testicular cancer. And finally, as our research has been refined over the decades from the initial studies with platinum, we are also looking at this as a model for a curable disease with a homogeneous type of treatment, and looking at late complications, or what we call the burden of the cure. What are these patients like 10, 20, 30 years later, and what can we do to try to mitigate some of these late complications? So when I was a medical resident and fellow, the drug that was used for testicular cancer when it has spread to the lungs and other areas of the body was a drug called actinomycin D. And it did have activity as defined in reduction in size and number of pulmonary metastases, and it actually had occasional cures. About 5 to 10% of these young men would actually be cured of their disease with actinomycin D or actinomycin D combined with other agents. Well, in the 1970s, other drugs that were developed, vinblastine, which is an Eli Lilly drug, and bleomycin, were competitive to but not superior to actinomycin D. But the combination of vinblastine and bleomycin was a synergistic combination, as it improved the cure rate to about 25%. But what revolutionized the cure rate in this disease was the discovery of the first heavy metal ever to be evaluated as an anti-neoplastic agent. And this is platinum, or its chemical name cis-diamine dichloropplatinum. Now, those of us who labor in the fields of phase 1 studies and first-in-human studies with new drugs, we have a kernel of enthusiasm when we see a modicum of activity with a new drug. But when platinum was first used in patients with testicular cancer who failed to be cured with actinomycin D, failed to be cured with vinblastine and bleomycin, and using this as third-line therapy, we actually saw 3 complete remissions, complete disappearance of disease, and 3 partial remissions in an 11-patient subset of a patient population. Now, this was single-agent therapy, third-line therapy. These patients all died, but at least it demonstrated that there was a new sheriff in town, that there was a new active drug with a unique mechanism of action, namely cisplatin. So with that as a background, when we develop combination chemotherapy regimens, it's very simple then and equally simple now. We first of all want to use drugs that are known to have single-agent activity, and cisplatin, vinblastine, bleomycin all have single-agent activity. We want drugs that have different mechanisms of cytotoxicity, and they all are unique in how they kill the cancer cells. We want drugs that do not have overlapping toxicity. If we give 3 drugs and they all cause very low blood counts, We're not able to give any type of decent dosage of the drugs. And fourthly, we want to have evidence of synergism, and certainly vinblastine and bleomycin is a very synergistic two-drug combination. Now, if there was a model for a curable cancer in the 1970s, it was a wonderful work from St. Jude's Hospital, which I'm pleased to see over here as one of the supporters and sponsors, with the outstanding work in curing childhood leukemia. And in that model, it appeared that we needed to give induction therapy with combination chemotherapy and then follow it with long-duration maintenance therapy to try to get total cell kill, to kill that last leukemia cell, or in this case, the last cancer cell. So our first phase 2 study, where everyone got the same treatment with this novel regimen, with this experimental drug platinum, gave induction therapy with the 3-drug regimen, and then single-agent therapy with vinblastine for a total of 2 years of chemotherapy. So even in my youthful exuberance, I never would have dreamed that the introduction of an experimental drug platinum would so change the face of this disease, going from a contemporaneous 5 to 10% cure rate to literally a 1 logarithmic increase in the cure rate, as over half of these patients were cured and never had further problems with their metastatic testicular cancer. Well, that was our phase 2 study. And over the years, we did a variety of phase 3 studies asking important therapeutic questions. Study number 2 demonstrated that we could reduce the dosage of vinblastine, lessen the myelosuppression with low blood counts, infection, and bleeding, reduce the neuromuscular toxicity from vinblastine, and maintain the cure rate. The third study is a very important study because we challenge one of the basic tenets in oncology about maintenance therapy. We felt that the miracle of this PVB regimen was the new drug platinum, not the older drug vinblastine. And so we did a study where we randomized 147 patients who were in complete remission to receive or not to receive 2 years of maintenance vinblastine. And there wasn't even a 1% difference, a total equanimity showing that we did not need to give those last 2 years of maintenance therapy. Now, if something works in Indiana, in Indianapolis, it should work all across the country, all across the world. And literally, if it works in Indiana, will it play in Peoria? This is data from Eric Foyer, who is an epidemiologist at the National Cancer Institute, looking at the introduction of platinum with the first abstract presented at a national meeting and the first publication, showing this dramatic national increase in the survival curve simply with the introduction of an innovative new drug, namely cis-diamine dichloroplatinum, or cisplatin. And just to show you some of the before-after chest x-rays from these early patients in the 1970s, this is a young man who came in severely hypoxic with shortness of breath, cough, and on his lateral view of his chest x-ray, there literally is no normal pulmonary parenchyma at all. All the white that you're seeing on there is tumor, and the very minimal black is normal air in the lung. Now, if this were any disease other than testis cancer, we would not have even offered this patient chemotherapy. But again, the goal was cure, and long ago we were able to accomplish that goal. This is another one of our patients. This is an abdominal CT scan, and you're looking at the liver, and those dark round areas that encompasses about half of the liver represents metastatic testicular cancer, again with platinum-based chemotherapy, disappearance of the disease, and long since being cured of his metastatic cancer. Now, I mentioned synergism, the idea that 1 + 1 can equal 3 rather than equaling 2. Synergism is very easy to document in a mouse model, and this happens to be a murine model called P388 leukemia. So you can inject tumor cells into the ventral surface of the mouse, and tumor nodules will develop and the mouse will die, and that's the control arm over there. The CDDP is cisplatin. When cisplatin is given in this mouse model, the mice live a few days longer. VP16, which is etoposide, when etoposide is given, it has some modest prolongation of survival. But when cisplatin and etoposide are given together, we see a 25% cure rate. Well, unfortunately, there's a big difference between mouse and men. It is very easy to cure murine leukemia. It is very difficult to cure a spontaneous tumor as opposed to a transplanted tumor, which is what mouse models are. And this is why animal models are being used less and less frequently as we have more sophisticated ways of looking at new drug development. But nevertheless, this showed that we have an effective two-drug regimen that had a rationale for combination. But we wanted to know whether etoposide or VP16 has activity. So we looked at it as a single agent in patients who were not cured with PVB, and it did show a partial but no complete remission rate in that setting. So this is the first time we looked at, in an adult tumor, trying to cure an adult solid tumor with second-line chemotherapy. And interestingly, the results were almost the same as in the animal model. Single-agent platinum would cure nobody as second-line therapy. Single-agent VP16 etoposide would cure nobody, yet 23% of these patients were cured. So this led to our next phase 3 study. We wanted to look at our control arm on top, which is a PVB regimen, cisplatin, vinblastine, bleomycin, and we wanted to do a one-on-one substitution of this promising synergistic drug with platinum, etoposide, compared to the older drug, vinblastine. So this is a phase 3 study designed as a superiority study to see if the new regimen is better than the older regimen. And indeed it was. First of all, the BEP regimen had less toxicity and also higher therapeutic efficacy with a 78% cure rate as opposed to a 66% cure rate. And after this phase 3 study was done, the PVB regimen became a historical footnote in favor of the newer BEP chemotherapy regimen. Well, after we did that particular trial, we did a next trial where we looked at patients that did not have massive disease like those before-after x-rays, and we compared 4 courses of BEP to 3 courses of BEP, 12 weeks of therapy versus 9 weeks of therapy. And this was not just eliminating a course of therapy. Platinum as a drug has cumulative toxicity, cumulative anorexia, nausea, vomiting, cumulative neuropathy with painful numbness and tingling in the hands and the feet, cumulative kidney damage, cumulative ringing in the ears and hearing difficulties, and bleomycin can cause cumulative pulmonary fibrosis, which on rare occasions can be fatal. So we did a study of 3 courses versus 4 courses, and once again, it was exactly the same. So as we look at 15 years of clinical trials, we were able to reduce the dosage of vinblastine, and we knew that by phase 3 studies, eliminate 2 years of maintenance vinblastine, substitute a better drug, etoposide, for the less effective drug, vinblastine, and shorten therapy from 4 courses of therapy to 3 courses of therapy. So we went from everyone getting 2 years of therapy to getting just 9 weeks of therapy for the majority of our patients and being able to cure their disease. Well, not all clinical trials that we do, that we try to innovate, wind up being positive trials like the ones that I demonstrated. Another active drug that was approved by the FDA for patients who were not cured with first-line therapy was a drug called ifosfamide, which is a classical alkylating agent. So we wanted to look at whether ifosfamide, a drug that has a fair amount of toxicity, would be better than bleomycin. So we compared the BEP regimen to what we call VIP, which is VP16, which is ifosfamide, VP16, which is etoposide, plus ifosfamide plus cisplatin. So a simple, again, one-on-one substitution. And unfortunately, this just produced increased toxicity without improved therapeutic efficacy. So BEP remains standard therapy. But even negative studies can be worthwhile because not everyone can get bleomycin. Bleomycin is a very dangerous drug in people over the age of 50 because of its pulmonary complications. It's a very dangerous drug in some of those patients on the before-after x-ray I showed. If they have massive lung disease and a little bit of bleomycin lung damage can be a fatal complication. So at least we knew that VIP, although it causes more nausea, vomiting, and low blood counts, is a drug that can be given equivalently to the BEP regimen. Now, Christine mentioned Lance Armstrong, and we talk in 2017 about personalized medicine. And of course, personalized medicine means instead of giving everyone the same therapy, we like to look at molecular characteristics and genomic analysis of an individual tumor. What is driving the cancer so that we don't treat all colon cancer, all breast cancer, all lung cancer the same way, because they're not the same disease even though they have the same label. But we can also do clinical personalized medicine. So Lance Armstrong was a professional cyclist. Bleomycin causes a reduction in the diffusion capacity, and probably any of us in this room would not have any detriment in our athletic acumen if we were to take bleomycin. But if you're a long-distance marathon runner or a long-distance cyclist, a slight decrement in your pulmonary function would eliminate your career as a professional long-distance cyclist. So we had just finished that negative phase 3 trial and knew that ifosfamide was more toxic, but we talked to Lance about getting the VIP regimen instead of the BEP regimen, and once he knew and saw the data that the results in cure were the same, he enthusiastically endorsed getting that. Now, Lance Armstrong, when he presented with metastatic cancer, not only had massive pulmonary metastases, but also had brain metastases. And back when he was diagnosed in 1986, the standard treatment for brain metastases was to treat the entire brain with radiation therapy. That would also eliminate his professional career because of balance problems and other things that are affected when you give people whole brain radiotherapy. So we did a one-patient experiment with his permission. We did not radiate his brain. We gave him chemotherapy alone. And prior to a second course of chemotherapy, one of our neurosurgeons resected a couple of his brain metastases with the idea if there was still cancer there, he would need the brain radiotherapy. But after just one treatment, the tumors in the brain actually had disappeared, not just on an MRI, but by resection of a residual mass. And in fact, today we no longer give whole brain radiotherapy to hardly anybody with diseases like metastatic testicular cancer with brain metastases. So this is Lance in happier times when he won the first of 7 consecutive Tour de France's, and he's been one of the major proponents for the cancer community in setting up the Lance Armstrong and now the Livestrong Foundation that has helped so many patients. Now, Christine also mentioned UV Singh. UV Singh was a cricket player. He actually tells me that's the #1 sport in the world. I don't know about that, but that's what he said. So he was the #1 ranked cricket player. He led India to winning the World Cup in cricket. And actually, at the time that he was performing at such a high professional level, this is what his chest x-ray looked like, with this massive disease in the middle of his chest. This is after 1 week of chemotherapy, with the mass being completely gone. And UV, of course, is also, like Lance, long since cured of his metastatic germ cell tumor. Well, when we treat patients with curative intent with platinum combination chemotherapy, we cure about 70 to 75% of these patients, which means 25 to 30% are not cured. So what do we do if we fail to cure patients with first-line chemotherapy? What we do is high-dose chemotherapy with what used to be called bone marrow transplant and is now called peripheral blood stem cell transplant. So basically what this means, we can take a chemotherapy drug and give it in 5 times the dosage, which would normally be lethal as far as bleeding, sepsis, and infection with low blood counts. But we can take patients' healthy blood cells, previously from the bone marrow, but now just from the peripheral blood, give these massive dosages of chemotherapy, and reinfuse a patient's healthy hematopoietic stem cells. The transplant is not therapy. The transplant allows us to give high-dose chemotherapy. So these are our results that we published in the New England Journal of Medicine with 164 patients. And it really is, to me, even in 2017, 40 years later, amazing that we can cure metastatic cancer by infusing cisplatin intravenously. But it's a miracle that we can take patients who are not cured with platinum and etoposide and give them massive dosages of platinum and etoposide and still be able to cure patients, as shown on this particular slide. So when patients get chemotherapy, these are the side effects that they have, and I just want to look at that first bullet point, nausea, vomiting, and emesis as it applies to innovation. So let me just go back to the 1970s. A patient would get a 5-day course of platinum. On average, on day 1 of the platinum, the patient would vomit 12 times. That's what chemotherapy used to be like in the 1970s. And just as in the 1970s when patients had pain from cancer, people would say, well, sure you have pain, you're supposed to have pain, you have cancer. Well, that's unacceptable. You want to look at what are the mechanisms of pain and how best to combat that. Well, the same thing with nausea and vomiting. So by doing studies and finding that after you inject platinum, that 5-hydroxytryptamine, 5-HT3, is secreted in very high concentrations, it then became a simple principle to develop drugs that are selective 5-HT3 antagonists. The first in class happened to have been a drug called ondansetron or Zofran. And that, just as platinum revolutionized the cure rate of testis cancer, so did these drugs revolutionize the severe nausea and vomiting that these patients had to endure. The median number of episodes of vomiting today is 0. Patients still have nausea, it's still unpleasant getting chemotherapy, but nothing like it was in the 1970s. Well, that's the acute toxicity. So in my career, I've had the blessing to be involved with developing a treatment that actually cured the disease. And during the first decade, we did a lot of work at trying to mitigate the nausea and vomiting. And now what we're looking at are the late complications that can happen with chemotherapy and how can we prevent them. And just for your information, as far as sterility, when we cure patients, 40% of the patients will permanently have a low sperm count and be unable to father a child. Again, these patients are in their 20s for the most part. This is why we offer sperm banking to every patient prior to starting chemotherapy. But the serious late complications are permanent neurotoxicity, ototoxicity, as well as second malignancies and cardiovascular disease. And I'll get back to that in just a minute over here. So, when platinum is given to a patient, and 10 years later, 20 years later, with atomic spec, we can look in the urine and in the blood, the platinum is still there. Whether that contributes to the late complications that can happen or whether something else remains to be seen, but that's a fact, and it's a worrisome fact. So when we look at our past and present research with this disease, platinum really was a breakthrough drug. We refined the cure with the phase 3 studies with lessening duration of toxicity and substituting etoposide for vinblastine, developing successful antiemetics that have revolutionized the severe toxicity people have. But now we're looking at the burden of the cure. So we are looking at, with GWAS, looking at genetic susceptibility to late complications of platinum. Not just for a curiosity to see how many people have an abnormal gene or abnormal protein that predisposes them to having durable toxicity, but can we do something about it? Like with the 5-HT3 story with developing ondansetron for nausea and vomiting. And this is much of our ongoing research at the present time. Well, this is the way a survival curve used to look like before platinum was around. On the bottom is stage 3 pulmonary metastases, where 90% of these young men would be dead within 1 year. This is what our survival curves look like now. Even those patients with stage 3 disease will have an 80% cure rate and overall 95% cure rate. Well, that's testis cancer, that's chemotherapy. Innovation and drug development now is no longer chemotherapy. It's become much more sophisticated. And it's nice as an oncologist to talk about testis cancer because it's such a highly curable disease. But this is the reality of cancer in an oncology clinic. Looking at the new cases and deaths with lung cancer, my other area of research, actually there are more deaths from lung cancer than there are from breast, prostate, colorectal, and pancreas combined. So this is an article from Doug Hallahan and Robert Weinberg, which looks at what makes a cancer cell a cancer cell. Why do cancer cells have a therapeutic advantage over normal cells? And this was updated 10 years later, looking at emerging areas of the cancer cell toolbox, if you will. And one of the most important of these is not just looking at molecular targeted agents with finding something that drives the progression of cancer so that we can develop a non-cytolytic drug to affect that, but also looking at why is cancer able to escape our normal immune mechanisms. Vaccines and forms of immunotherapy in the past have been dismal failures, but we learned that just trying to stimulate the immune system isn't enough. The cancer cells develops a blockade, and we have to figure out how to open up that blockade to allow the immune cells to get through to cure the cancer, or at least treat the cancer. So studies with immune checkpoint inhibitors have really revolutionized how we treat common cancers at the present time. So these are some of the molecular targeted agents that have really revolutionized how we treat common diseases like breast cancer and lung cancer, and particularly in lung cancer, the discovery of EGFR epidermal growth factor receptor, or ALK anaplastic lymphoma kinase, in patients who primarily are non-smokers with lung cancer, offers patients to live with cancer rather than dying of cancer. These drugs don't cure the disease, but they greatly prolong survival and improve quality of life. And this is a cover of Science from about 3 years ago, looking at immunotherapy, and immunotherapy is now joining surgery, radiotherapy, and chemotherapy and molecular targeted agents as an important mechanism of treatment of cancer. So I want to end up with going back to old-fashioned chemotherapy, platinum, rather than molecular targeted agents or immunotherapy. So the person who discovered platinum was a biophysicist at Michigan State, and this is a great story of innovation. In the late 1960s, and this seems very primitive, the thought was that physical agents like hyperthermia or electrolysis can improve the ability of radiotherapy or chemotherapy to get through the cell membrane and to kill the cancer cell. So Dr. Rosenberg set up a water bath solution, dumped E. coli in the solution, and ran this electric current to see what the effect would be upon E. coli, which is looking at an effect upon DNA. And he found a phenomenal biological effect with disillusionment of the DNA and affecting the single strand of DNA. And he was clever enough to realize that it couldn't possibly be the electric current per se. And guess what? The electrodes were platinum electrodes, which were seeped into the water bath solution. No one had ever thought of looking at a heavy metal as an anti-neoplastic agent. So platinum went through clinical trials. It had a spectrum of activity in many diseases, but horrendous toxicity, kidney failure, deafness, neurological problems, and the horrendous nausea and vomiting. But just as platinum has saved the lives of hundreds of thousands of young men with testis cancer saved the life of platinum. Because if we weren't seeing these dramatic events with treating testicular cancer, we wouldn't realize that we can prevent nephrotoxicity by just simple saline hydration, developing nausea and vomiting agents, and showing that this drug can be given safely and easily, as it certainly is in 2017. And even though it's been 40 years, platinum remains the #1 first-line chemotherapy for these 11 different diseases. And I'm going to end over here with a statement that was made 15 years ago by George W. Bush's appointment of Andy Eschenbaum to the director of the NCI and later to director of the FDA. And he said, as you can read, and this was from 12 years before 2015, our goal is to eliminate pain and suffering from cancer by the year 2015. So to paraphrase President Trump about healthcare, it's more complicated than you think it is, getting rid of cancer. And this is science fiction, to think that we're going to eliminate pain and cancer and suffering and death from cancer. It's a very complicated disease with many complicated molecular underpinnings. And this, of course, is science fiction, this type of statement. And this is a science fiction poster of H.G. Wells' War of the World with that great Scientologist, Tom Cruise, who was in that movie. And so my last slide is a quotation from H.G. Wells, who wrote War of the Worlds from over 100 years ago, which states, and I can barely read it from here, the disease of cancer will be eliminated from life by calm, unhurrying, persistent men and women. Men and women, this is over 100 years ago, working with every shiver and feeling it controlled and suppressed in hospital and laboratories. And the motive that will conquer cancer will neither be pity nor horror. It will be curiosity to know how and why. So with that, I'll end, and thank you very much for your attention.
Thank you so much. Thank you.